pressure on.
Lots of pressure. Nice to meet everybody. My name's Dan Smith. I'm one of the neurologists here in the tower here. And then actually, to tell you the truth, I spend most of my time in Pickerington, which is where I came from. So sorry that I'm late.
Okay.
Had the traffic on the way in. But Pickerington and then at Grant as well. This is going to be extremely informal. At any point, if you have questions, stop me at any time as we go. But what we're going to do today is talk about a group of symptoms that I think are important, commonly maybe some of the things that we tend to maybe ask about the least in our MS patients. Some symptoms that can have a huge impact on somebody's quality of life, and a lot of times goes under the radar. Maybe isn't being brought up, maybe we're not asking enough. So I thought we'd kind of go through what types of things we come across and that our patients come across in regards to bowel, bladder, and then sexual problems in MS. So I'm going to start off with a case. This is just an example of somebody. This is not a real person, but an example of something that we may commonly see. So this is a gentleman named Matthew. He's 48 years old. He has had MS since he was diagnosed when he was 32. So he's had it for about 16 years now. And on a day-to-day basis, he notes that there's a lot of problems that he has, specifically in his legs. He's got weakness in both legs. He has a little bit of trouble with balance. He has numbness and tingling. He has gone through a large amount of physical therapy and done really well. It's helped him with balance and it's helped him with his movements. And he has spasms in the legs, and he's on muscle relaxing medicines that help loosen up the muscles. He's on gabapentin, which is one of the medicines that we use to help with numbness and tingling in the legs. And all of these things seem to help him. He comes in to clinic quite regularly, 3 or 4 times a year, and we check on him, we talk to him, we ask him what's new in his life, we ask him if he's had any new symptoms. We do an examination to be sure that he has not had any new changes. We check a scan of his brain once a year to be sure that he's not having any signs of breakthrough MS activity. And he's done pretty well. He hasn't really shown much change, but importantly, he is struggling with a lot of things that we're not aware of. So he has a lot of depression and anxiety regarding these symptoms, and it's something that we have not asked about, and it's something that he hasn't necessarily brought up either. So for one thing, he works as a writer, so everyone needs to be awake, but in particular in the morning, he needs to be awake and alert, and he cannot stay asleep because he is constantly waking up at night to use the restroom. And he will urinate 7, 8, 9, 10 times a night, and it will not really ever get sound sleep because of that. And he's falling asleep at work right at his desk because of it. And he's got a lot of abdominal pain that is a chronic complaint for him from constipation that he has. He has erectile dysfunction, and that's impacted his relationship with his wife, and that has resulted in intimacy problems and has also been another source of depression for him. So as you can see, he has a lot of things that are extremely important, very much impacting his quality of life, and we're not really looking into them. This is a picture of what his spinal cord looks like. This is an MRI of his cervical, or the top of the spinal cord, and he has, the spinal cord is the black structure right down the middle. In the front, he has, these are the bones, and right back here, these are the bones that you can actually feel through your skin here, we call them the spinous processes. The white things along the sides, that's just fluid, that's spinal fluid. You can see those arrows. The arrows are pointing to 2 spots where he's had MS attacks before, right in his spinal cord. And those are a common place. We'll talk a little bit more, but that's a common place to have MS that can sort of bring about these sorts of symptoms on a day-to-day basis. So How important and how asked about are these symptoms? This is a really new study that just came out, and it was a survey of a lot of people. So over 9,341 patients with MS were asked about their bowel, their bladder, and their sexual symptoms, and how often their neurologists were asking about these questions. The majority of the patients were female, around 77%, and they were about 50 years old on average. And when you look at this big group of people, they reported that only 60%, 6 out of 10, were being asked by their doctor about their bladder. Only half about their bowel movements and their bowel patterns, and only 20% about sexual problems. So very low compared to a lot of the things that we, tend to ask about, like walking and strength and cramps and pain and numbness. Only 1/3, 33%, were satisfied with the treatment for any of these symptoms. So what we'll do maybe is we'll kind of go through bladder, we'll go through bowel, and we'll go through the sexual symptoms, and we'll talk a little bit about the types of symptoms. We will, just to kind of show you how it all fits together, we'll talk a little bit about the anatomy of the brain and the spinal cord and how that can impact these symptoms. We'll talk about some practical everyday advice, tips that help with a lot of these symptoms. And then we'll go through a little bit about, but not in super detail, but kind of overviews about the medicines that we have and why we use them and how they can help. So there are 3 types of bladder problems that people have. The first one is called failure to store. And this is the most common thing that we see. And this is essentially as soon as our bladder starts to fill with urine, there's like an excitability to it. That as soon as the bladder sees that urine, in a perfect world, what we'd like to have happen is the bladder be able to at least store some urine and wait until a certain period of time and then say, hey, I need to be emptied, so that someone can have a full void. But as soon as urine gets into the bladder, there's an immediate release, and it can lead to symptoms of urgency, which is needing to go suddenly, without warning, frequency, which is just more and more trips to the restroom, among other things. Failure to empty is just what it sounds like. In this case, what we see is that the bladder can fill with urine pretty well, but when it comes to actually getting rid of it, we see that the muscles that are involved in opening the gate, so to speak, to let the urine come out are in spasm. And so as a result, the urine is staying in the bladder and it just cannot really come out fully. And so someone will try to go and they will just feel a partial emptying, incomplete emptying, and sometimes that can set up urine not really ever fully getting out. And sometimes we see that urine, that's one common time we'll see urinary tract infections happen in that setting. And then there's mixed, and to tell you the truth, mixed is the most common thing. Mixed just means that somebody has a combo of those two things. They have some inability to store the urine, they have some inability to empty the urine, and the type that predominates can vary, but I'd say that the majority of the time, patients we see, probably most of the time, at least complain of the failure to store, going frequently and going suddenly, kind of without warning. And so we kind of touched a little bit about this, but the symptoms that we'll hone in on are urgency, suddenly needing to go without warning, frequency, going more than we would normally expect, incontinence of urine. We'll see hesitation, oftentimes when the bladder cannot empty fully. We'll see that there's a hesitation in starting the stream of urine and getting everything out. And then urinary tract infections, super common as well in this setting. And so here is how complicated all this stuff gets. There's all kinds of circuits that we have that basically control our bladder, control our brain telling us how much we have in the bladder, controlling the muscles just in the right sequence so that they can squeeze the bladder in just the right way to get the urine out. And of course, the signal has got to pass all the way from up top, all the way down the spinal cord to the very bottom of the spinal cord, where there's lots and lots of nerves. And then those nerves come off like spaghetti, I sometimes say, at the very bottom of the spinal cord out to the bladder. So there's a lot going on. The very front part of the brain, or the frontal lobe, is one big important part of our brain when it comes to urination, and that it inhibits it. So if there's a problem up there, if MS has caused lesions in our frontal lobe, oftentimes that break is let's go. And we see urgency and we see frequency happen a lot more commonly. But there's more than just the brain itself. There's also the brain stem. The brain stem is this stuff down in here. It's the part of the brain it's the most ancient part of our brain that we have. It controls all kinds of things like our breathing, our heart rate, our eye movements, a lot of the things that are kind of more at the unconscious level instead of the part of our brain where our thinking takes place. And there are centers within the brain stem. One is called the midbrain. It's this red area right here. And then the pons, or the pontine area, which is the blue area. We see that the midbrain is also a brake. It's a brake on urination. And so if you have trouble there, if you have an MS spot right in that area, the brake comes off and we see too much or too quickly urination coming. But if you have a problem in the pons, sometimes it's the exact opposite. You need that pons to make it come out. And so when you have something in the pons, it's the exact opposite. And so you can see how there's all these little areas where there's communication and then there's passing the signal down for what's supposed to happen. So if I have MS and I have spots within my brain and my brain stem, and then maybe even down here in the bottom of the spinal cord, if I have it in all those areas, you can see how complicated it can get in terms of what type of urinary problem I might have. And that's a lot of times when we see this kind of mixed thing that I mentioned earlier, kind of a mix of going too often as well as not being able to empty all the way. Questions so far?
I was just wondering about hold on, the red area that looks.
Yeah, over here.
Yeah. Is that the midbrain?
That's the midbrain. Yep, that's the midbrain, which does many things, but for the urinary circuit, it's sort of like a brake on preventing it from happening when it's not supposed to.
Okay.
Yep.
The pictures look a little different, because like the one that shows has the line that shows on the bottom.
Down here?
No, bottom right.
Oh, yeah.
Picture, it looks different than the top right.
Oh, yeah, you're right.
That's what I'm talking about.
Yeah, I should have made this a little bit. So this part up here is just kind of highlighting what the brain, not the brain stem, but we call the cortex, does. This area right here, this midbrain, this brain stem is made up of 3 parts: midbrain, pons, medulla, and that is this.
Gotcha.
Right there.
I was misled by the big red.
Yeah, sorry.
thing.
So it's just, this is kind of like highlighting that part of it.
All right, thanks.
Yeah, no problem. But there's a lot of, as you can see, there's a lot of circuits. So it's pretty complicated stuff. And the thing that I didn't really go into much detail, but I should now since we have it up, is we talked about the brain and we talked about the brain stem, but then you've got the spinal cord. So the spinal cord is the highway of all the information that needs to travel from all the way down to our bladders. And it's not done, because even when it gets down all the way to the bottom, it has to come out and go through nerves out to the bladder. So there's a lot of places where trouble can come up, where trouble can arise. So these are some tips that I talk to my patients about a little. Tips, they can actually make a pretty big difference. Not every time do we have to go right to medicines, although we will talk about those medicines and what they can do. But one common thing that I always stress is to help prevent urinary tract infections. We talk about drinking as much water as we can and staying hydrated, and that is hard to do. I cannot do it. I try to stay hydrated throughout the day, and I always am forgetting to drink water or not drinking enough water. So the one thing that I always say is to drink a glass of water before each meal. And that gives you 3 right there. And then between meals, between your breakfast and your lunch, and between lunch and dinner, drink one there. And that's going to give you 5 big glasses of water right there. It helps so much because it's so easy to lose track of what's going on as the day goes on. But it's important to try to drink as much as you can early on, because the more we fill the bladder up later in the day, as you can imagine, the more we're going to need to get rid of before we go to sleep. And so if we can front load that water, it works out better. Try to not drink too many fluids after dinner, just so that we can keep hydrated throughout the day, but not super full of liquid at nighttime. There are certain fluids that may be more irritating to the bladder than others. Not that we can't have these, but we'll see that particularly alcohol and certain things with carbonation, pops, may be something for certain people that is a trigger to have more of these urinary problems. And so I'll say, keep an eye on those and see if you feel worse after you have a soda. Is that something that's a big trigger for the symptoms later in the day? And if so, not that we can't ever do that, but try to go more down the route of water as much as possible. Sometimes what we'll do is we'll try to do timed voids. And so timed void is when, and it depends, everyone's a little bit different on if this is the appropriate strategy or not. But what I'll try to do, in particular if someone is having a lot of kind of an irregular pattern to their day in terms of how many times they're going, I'll say, try to go to the restroom every 2 hours and see what happens. And if it gets to a point where you're finding that you're not needing to go, take that interval of time and space it out a bit. Maybe do 2.5 hours, maybe do 3 hours. But what it does is it gives you a system. It gives your bladder some regularity. You're going consistently, you're emptying consistently, and it can help quite a bit. And oftentimes your internal rhythm will get used to going at that frequency, and you'll find that when you go, it's a more effective time that you spent. You got a good amount of urine out kind of in one time in a consistent way instead of certain days maybe going 10 times and then other days going 5 times. So that can be a helpful tip. Constipation matters too. If someone is really struggling with constipation, you're going to have a lot of straining, and the more straining you have, sometimes it's going to have spillover effect into the urinary system, and we'll see incontinence come out of constipation problems as well. And another really helpful thing there are exercises that are available to help strengthen the muscles of the pelvic floor and the bladder. So there are pelvic, and we'll talk about it in a minute, but there are pelvic floor physical therapists who are awesome and can give us ways to first learn about the anatomy of what we have around our bladders, and then also ways to help strengthen some of those muscles. And this can make a big difference for people as well. So pelvic floor physical therapy is probably underused. We should use more of it. They teach us, it's amazingly complex how many muscles are within the area of our bladder and our perineum. Educating on what those muscles are, what they do. Ones that are squeezing and spastic can be loosened up. Ones that are weak can be strengthened. And a lot of times it helps with some of the urinary symptoms. And this is offered at a lot of locations throughout the whole system. And so definitely here, definitely at Burlington. And I know there are several places around that offer it, but ask about this, because this is a really helpful thing sometimes that I think that we forget to ask about. So when we see somebody, these are things that we think of. When someone says to me, I am having a lot of, I'm going to the restroom too many times a day, especially if it's a sudden change, the first thing we always say is, gosh, could it be a urinary tract infection? And so in clinic, especially if it's a sudden change, we will look really hard for that possibility, because an infection is one thing that can brew and can lead to more times of urination, and it can be very, very subtle. It doesn't have to be full-blown fever and all this. It can be these subtle urinary changes. We do a bladder scan, which is what this is. So the bladder scan is an ultrasound placed on the lower abdomen, and it will give us an accurate reading of how much urine is left in the bladder. The way to do it is to have a void to completely empty the bladder and to see on the bladder scan how much is left. Because we want to see after somebody voids, are they having too much left over or not? When someone goes completely and we do the bladder scan and we find that there's really not much urine left, there's a low amount of it, and this is kind of somewhere between 50 and 100 is the amount that we look at, milliliters of urine. When it's low, sometimes that tells us that maybe the problem is in just too much irritation. The bladder is too excitable, and we use medicines that tone down the frequency of the contraction of the bladder. But sometimes someone will go, they will empty their bladder, and when we do the bladder scan, the problem is that there's way too much left over, and so this is the failure to empty. And this one is trickier because we don't really want to put all these medicines on for someone in that case. We actually want to be sure that the urine is coming out the way that it should, because when it's not, maybe that's a setup for urinary tract infections. This gets trickier, and a lot of times we will use our colleagues in urology to help us figure out someone's urinary cycle, maybe what would be a better approach for them instead of doing one of these medications. And we'll talk a little bit about them in just a little bit. So there are all types of medicines that are used. One big type that we use, us neurologists use, are these ones that have been around a long time. They're tried and true, and we know that they help. They all, in general, the one that I use quite a bit is this one called Ditropan, or oxybutynin is the generic name for it, and we use Detrol quite a bit. Amitriptyline. These are all basically medicines that help to tone down a frequent spasming bladder, reduce those types of symptoms. And they can be very, very helpful, and a lot of them have benefits at night. They help with sleep. You can sleep better. They may help, particularly amitriptyline, although it's spelled wrong there, can help with pain and tingling. So there can be overlap benefit of these types of medicines. There's other ones that are a little bit more fancy and that do other types of things to help. Sometimes there's this one called desmopressin, and it helps someone who is just going frequently throughout the night, particularly at night. There are some that when the bladder is in the state of not being able to empty, they help relax the outflow tract that gets tight, and when that gets tight, the bladder can't empty. So we use this one, which is also called Flomax, to help relax a bladder that can't empty. There's other ones that stimulate the bladder itself to squeeze a little bit stronger when it's weak. And there's all kinds of fancy ones that have come out that oftentimes we will use our urology colleagues. They will help us quite a bit with these new ones because they do a lot fancier things more effectively sometimes than the old medicines. And so there's a lot available. They can even do procedures to help with urination. There is Botox, which is it is the cosmetic Botox, but it is not used for that purpose. The Botox relaxes stiff muscles. And so we'll see that they can actually go in and inject a bladder. This is the bladder, this is the inside of the bladder. Wherever the area is, and I'm simplifying this a lot, but the areas that are tight and squeezing, they may be able to inject Botox there, loosen up the muscles so that there can be better flow of urine. Sometimes maybe the signal is not going very well down from the brain through the spinal cord out to the bladder. There's a sacral stimulator, which is a device which produces an electrical current, comes down through these nerves and attaches to where the bladder is, and it can help stimulate a bladder squeeze. They can help us in someone who is needing to catheterize often. They can help also determine whether or not someone may benefit from a permanent outflow of urine or a suprapubic catheter, which is a permanent insertion of a catheter in cases as well. And so they help us in many, many ways. There are ways to prevent UTIs. The big thing I always stress is staying hydrated, drinking plenty of water. And we, as neurologists, need to help treat any urine that is not coming out. So if I am someone who has a bladder that's not emptying fully, I urinate and then you bladder scan me and you see that there's still a lot left, I'm someone that would benefit from some type of medication to help get more out. So that there's, because the problem is when we see that the urine is staying in the bladder too long and too much, it becomes sort of like a place where bacteria loves to go. And bacteria can just live there and create an infection. And so that's why it's so important to get it out. There are some things, some people have tried cranberry extract, and that can help, it can help. It's a little tricky though, because certain types of urinary infection bugs are more responsive to that than others. So E. coli is a common one that may respond to it, but others don't. There are sometimes prophylactic antibiotics or taking an antibiotic all the time in some cases if someone gets a lot of urinary tract infections. It gets to be a little bit more complicated, and usually these are types of things that I will rely on our urology colleagues to help guide us. Does someone need a prophylactic antibiotic? By that point, it's usually something that the urinary specialist is helping us with. And also probiotics too, we're finding supplementing your body with normal bacteria in some cases may help prevent the bad stuff from building up. So Dr. Shaw is an example of one urologist who sees all of urology, but also did fellowship training and has specialized interest in all of our patients who have bladder problems related to neurological injuries. And MS is super high on the list. Yeah?
We see Dr. Shaw, wonderful. Shout out for Dr.
Thank you.
He knows what he's doing.
Yeah, so he's awesome. He has a serious passion for our patients, and he talks at our, we have some continuing medical education events where we're talking to like other docs and nurse practitioners and nurses and stuff about MS, and he'll come and talk about the latest in bladder care, and so really, really, really helpful. All right, so we'll change gears a little, and we'll talk about constipation. Another very common symptom. Why does it happen? So lots of reasons. Just like I mentioned that the signals need to get from the brain down through the spinal cord, down to the nerves, when it comes to urination, we have the same problem for the passage of our food and our stool through our intestines. And also, when someone has MS, in general, we're going to see the following. Less, sometimes, activity, right? Not as much exercise as we used to get. And those things, in and of themselves, are a setup for constipation. Like when someone has been hospitalized for whatever reason, as an example, for a few weeks, oftentimes people leave the hospital constipated just because they haven't been doing the amount of activity that they normally do. And that activity is helpful in stimulating our gut. Also, not drinking enough fluid. So maybe there's a problem with our urinary system, and we're not drinking enough fluid, or maybe we're having trouble getting the fluid in the first place, which is what dysphagia is having trouble swallowing. But not being adequately hydrated also affects our bowel movements. So you'll see a recurring theme here. How can we help on a practical day-to-day basis prevent constipation, stay hydrated? And fiber. Fiber is a really, really big deal. Fiber can be found in a lot of common everyday foods. So you don't have to necessarily go right to a fiber supplement. You can introduce fruits, whole grains, vegetables, nuts, and legumes, and it will help. We also have some of us have like a little chart that has, and you can get these online, of all like common foods and the amount of fiber that's within each one. There are fiber supplements that can be added. They can be added and mixed in with like with liquids, with applesauce, with fruit juice. But fiber is a big deal. There is this kind of little recipe that we used to use where I'll actually have down here on the bottom, unprocessed bran, applesauce, and prune juice. It really does the trick. You can take 1 tablespoon of that a day and then increase as needed. It's just a huge amount of fiber, but it really, really, really does help a lot of times. Prune juice can be helpful. And then there's a lot of nutritional supplements for calorie purposes, but then also that have added fiber in, like Ensure and Boost. They have an increased fiber version of both of those that you can try. It's important to try to limit caffeine and alcohol as those things are constipating. Exercise as much as can is a big, big deal. There are certain foods which are notoriously constipated, particularly cheese and refined grains. So the gastrocolic reflex, that is the normal sensation that a lot of us have after you eat a meal, 10, 20, 30 minutes later. It stimulates our bowel to start going. And so a lot of people have that, and you will feel this reflex come in, so take advantage of it. If it is there, be ready to say, hey, this is a time when I may be able to have a bowel movement, and watch for that. And then this is something that we do. A lot of times we are prescribing medicines, and they have good intentions, but constipation is a common side effect of a lot of antidepressants. And if, and someone who has chronic pain that may be on like an opiate, like a narcotic, that's a big time notorious guy for causing constipation. Iron supplements will do it too. Warm liquids can help stimulate the bowels as well. So sometimes if someone is having a problem with constipation and we look at their medication list and we see what are they taking, is there something that could be making it worse? And we check that box, and then we say, well, how much fluid are we drinking? Are we drinking enough fluid? Are we staying hydrated? So we check that box. And maybe someone has tried to add in fiber. They've added a lot of fiber in, it's still just not quite getting the job. That's kind of where the role of some of these medicines come in. And there's all types, but in general, we sometimes will use Senecot or Miralax, which are laxatives, to help loosen the stool burden, and then a stool softener like Docusate. We'll use these together, and that will help. Sometimes it's not quite enough, and then generally, if one of my patients is having a really hard time having a bowel movement, we've tried all these things. I usually say, let me know if this is an ongoing issue, and if it's been a few days. At that point, sometimes we need to use enemas, or you can manually disimpact as well. But there's ways around these problems. The main point is to basically reach out if these strategies are not working. And I try to make it a checklist to make sure we're hitting all the common and easy fixable things first. But sometimes it's not enough. Questions on anything so far? So we'll talk a little bit about sexual dysfunction as well. Remember, the most asked about symptom of all, probably. 20% in that large survey that I showed you had been asked about this question. So there's different reasons why sexual dysfunction can happen. We say that there's this thing called primary dysfunction. This basically means that there is a problem somewhere in the circuits between what our brain perceives passing down through the brain stem into the spinal cord to our nerves and to our genitalia. And as a result, there's not oftentimes the same sensation that is processed upwards. And this is a frequent reason why we see problems, sexual problems, difficulties with arousal of all different types. We see secondary dysfunction, and this is a little bit different. This means it's not so much a problem of not being able to feel something as much as it is, gosh, I have terrible spasms in my legs. Every time I try to have intercourse, I can't because I'm going into a spasm and it's so painful. Or bladder retention, urinary retention, pain of any kind. Basically some symptom that the MS is causing that's impacting our sexual life. And then there is a thing called tertiary dysfunction, and what that means is, and this isn't specific to MS, but oftentimes when someone has a chronic illness, there can be a depression, and there can be a body image that develops, and it impairs and it affects our sexual life as well. So we need to think about sexual dysfunction kind of broadly in all three ways. And this is something we talk about, and it seriously is very important, but in primary sexual dysfunction, a lot of times there's a sensation difficulty when someone is not feeling the same stimulus that used to work for someone no longer does. And we will talk about these types of things without hesitation because it can make a huge difference in someone's quality of life. But in truth, we see things like vibrators that can be very, very helpful. Someone needs more stimulus than what they previously used to require because of that circuitry. In Viagra, we use quite a bit, and I would say very, very commonly, and can be a very helpful medication to think about. We need to work on treating pain, treating muscle tension, treating these things that are causing secondary sexual dysfunction. And sometimes we need to look for low hormones. It's not very uncommon to have low testosterone levels as well, and that may not be helping someone's sexual symptoms. Avoiding certain medicines we prescribe, just like we talked about for the constipation. There's a lot of medications that we prescribe that may help another symptom but have a big impact on our sexual health. Antidepressants are a notorious one, and some blood pressure medications as well can impact that. Sex therapists are a very helpful another group of people to employ, and there's lots of sex therapists that are within the Columbus area and nearby areas. We highly recommend and can be a really, really helpful resources as well to sort of pull everything together, to look at someone's sexual health, to help us figure out maybe things we're missing. Is this all because of painful spasm, or what else is going on? Is there a body image symptom as well? And they can help counsel, and they can help couples and help individuals really improve quality of life quite a bit. So that pretty much wraps up what I wanted to talk about. But the big things I think I wanted to kind of highlight are just the fact that these symptoms can be embarrassing to bring up, but should be brought up. And we should be asking, by the way, as well, because the impact on quality of life is massive and probably under-recognized, under-treated. Lots of ways that can be helped, that people can have a benefit. It doesn't have to be crazy things. It can be these little tips, these little lifestyle tips and tricks, diet tips and tricks. Medications can help. There's a role in sometimes for devices, like we talked about, for some of the urinary symptoms, bringing in other doctors from other subspecialties like urologists, pelvic floor physical therapy, sex therapists, all different ways to try to help. And that is pretty much all I got. Thanks. So it's a little bit of a whirlwind of information, but
You take MS out of the picture, like the bladder and bowel issues, just aging. How does aging in the human
affect it?
affect it? 'Cause
Yeah.
every time I notice something different, and I talk to my wife, I said, not everything in your life is the MS. It's like, I don't know what is the MS and what's not, so I'm always talking to Dr. Nicholas.
That's such a good point. It's true that it's not always, it's not every time going to be just the MS. So we will, it's true, there is some element of wear and tear on our circuitry. And by living life, by the way, if anyone has like neuropathy, like as an example from diabetes, that's a common reason for neuropathy, but there's other reasons, but those nerves can get affected by, say, diabetes and cause the exact same types of symptoms that we're talking about, or at least kind of make things worse. And so it's true. It's definitely not always the MS. There can be other things. And living life is there's going to be some role of that. But everyone's different, you know. But just ask. Is this normal, you know? And I think it's important to keep reevaluating.
Where's the picture taken?
That is Copenhagen, Denmark. It was awesome. I would go back again if you twisted my arm. Yeah, it was really, we went there, took a vacation a couple months ago, and it was great. Yeah, it was a little canal full of boats. It's where, so Hans Christian Andersen, the children's author, lived there and wrote a bunch of his works, was in one of those. It's on the other side, he's over here, but he lived and wrote out of one of those apartment buildings, so. Yeah. Did you go there? Did you?
I wish.
It's cool. All right, well, thank you, everybody.
Thank you.
Thanks for coming out tonight, this evening. Sure, absolutely.